Perthes disease, non-surgical treatment. Perthes disease, which is also called idiopathic avascular necrosis of the femoral head, is a rare childhood condition that affects the hip. It occurs when the blood supply to the rounded head of the femur, thigh bone, is temporarily disrupted. Without an adequate blood supply, the bone cells die, a process called avascular necrosis. The ball part of the femur can eventually collapse when the bone is weakened, if the blood supply is interrupted long enough. When the blood supply returns to the ball of the femur, the bone can improve its strength, but the shape of the femur can be permanently distorted. Most children with Perthes disease eventually recover. It is really a complex process of stages that can last several years. Perthes disease takes place in 4 phases. Phase 1, necrosis stage. In this stage of the disease, the blood supply to the femoral head is disrupted, and bone cells die. The area becomes intensely inflamed and irritated, and your child may begin to show signs of the disease, such as a limp or different way of walking. This phase can last from several months up to 1 year. Phase 2, fragmentation stage. Over a period of 1 to 2 years, the body removes the dead bone beneath the articular cartilage and quickly replaces it with an initial, softer bone. It is during this phase that the bone is in a weaker state and the head of the femur is more likely to collapse into a flatter position. Phase 3, reossification stage. New, stronger bone develops and begins to take shape in the head of the femur. The reossification stage is often the longest stage of the disease and can last from 1 to 3 years. Phase 4, remodeling stage. In this stage, the bone regrowth is complete and the femoral head has reached its final shape. How close the shape is to round will depend on several factors, including the extent of damage that took place during the fragmentation phase, as well as the child's age at the onset of disease, which affects the potential for bone regrowth. Perthes disease usually affects children between the ages of 4 and 8 years, but the range can extend to between 2 and 12 years old. It is 5 times more common in boys than in girls. But when girls are affected, the condition tends to be more severe. For the majority of children with Perthes disease, only one hip is ever affected. Both hips are affected in up to 15% of children, but both hips are usually not affected at the same time. If both hips are affected at the same stage of disease, that suggests multiple epiphyseal dysplasia (MED). Causes and risk factors. The cause of Perthes disease is unknown. It often affects children who are very active. It is associated with attention deficit hyperactivity disorder, ADHD, in 33% of cases. There may be a genetic link to the development of Perthes. In fact, between 2 and 10% of children with Perthes disease have at least one family member with the disease. Exposure to secondhand smoke may also increase your child's risk of Perthes disease. Blood clotting disorders may contribute to the development of Perthes disease. Steroid use. Low birth weight. Abnormal birth presentation are also considered as risk factors. Symptoms. Painless limp. One of the earliest signs of Perthes is a change in the way your child walks and runs. Your child may limp, have limited motion, or develop a peculiar running style. You, as the parent, may be the first to see them while watching your child play. Some children don't feel much or any pain at all, but others may feel an intermittent pain in the hip or groin, or in other parts of the leg such as the thigh or knee that gets worse during activity and improves with rest. Pain occurs without an injury associated. Stiffness or decreased motion in the hip joint, especially internal rotation and abduction. shortening of the affected leg, leading to uneven leg length. It is a late finding. Diagnosis. To get a better understanding of the situation, your doctor will ask you when you first noticed the symptoms, what makes the symptoms worse, what makes them better, if there are any other health issues. Your doctor will also conduct a thorough physical examination, which will involve moving your child's legs through their range of movement. He will assess your child's range of motion in the hip. Perthes typically limits the ability to move the leg away from the body, abduction, and twist the leg toward the inside of the body, internal rotation. One specific test that your doctor will look for is a so-called Trendelenburg sign. When standing on the affected leg, an abnormal tilting of the pelvis is indicative of weakness in the abductor muscles of the hip. This Trendelenburg sign is often seen in children with Perthes disease. If Perthes disease is suspected, the provider will obtain X-rays of your child's hips. Initial X-rays might look normal because it can take 1 to 2 months after symptoms begin for the changes associated with Perthes disease to become evident on X-rays. Your doctor will likely recommend several X-rays over time to track the progression of the disease. Early findings on plain radiographs. Widening of joint space. Calve's sign or crescent sign, which is a subchondral radiolucent fracture line parallel to articular surface of femoral head. This sign may be visible prior to fragmentation stage. Later findings. Fragmentation of femoral ossification center. Lateral subluxation and flattening of femoral head. MRIs often can visualize bone damage caused by Perthes disease more clearly than X-rays, but are not always necessary. Bone scan may be part of evaluation if diagnosis is in question. It reveals decreased perfusion to femoral head. Treatment. About 60% of children with Perthes disease recover without any treatment, especially very young children, those 2 to 6 years old. It is important, however, for all children to be carefully followed up by their doctor during the course of the disease. They usually have to attend clinic every 3 to 4 months for examination and X-rays. In that way, children that are at risk of doing less well are identified and treated accordingly. The doctor will recommend a treatment based on the degree of your child's hip pain, stiffness, how much of the head of the thigh bone has collapsed and the age when symptoms began. The aim of treatment are resolution of symptoms, restoration of range of motion and containment of hip to protect the shape of the femoral head. Painful symptoms are caused by inflammation of the hip joint. Anti-inflammatory medicines, NSAIDs, are used to reduce inflammation and pain. Your doctor may recommend them for several months. As your child progresses through the disease stages, your doctor will adjust the dosage or discontinue the medication. Avoiding high-impact activities, such as running and jumping, will help relieve pain and protect the femoral head. On occasion, your doctor may also recommend crutches or a walker to prevent your child from putting too much weight on the joint. Physical therapy exercises are recommended to help restore hip joint range of motion. These exercises often focus on hip abduction and internal rotation. Parents or other caregivers are often needed to help the child complete the exercises. If range of motion becomes limited or if X-rays or other image scans indicate that a deformity is developing, a cast or brace may be used to keep the head of the femur in its normal position within the acetabulum. Petri casts are 2 long leg casts with a bar that hold the legs spread apart in a position similar to the letter A. The doctor will most likely apply the initial Petri cast in an operating room. During the application, your doctor will take a series of special X-ray images called arthrograms to see the degree of deformity of the femoral head and to make sure he or she positions the head accurately. In an arthrogram, a small amount of dye is injected into the hip joint. In some cases, the adductor longus muscle in the groin is very tight and prevents the hip from rotating into the proper position. Your doctor will perform a minor procedure to release this tightness, called a tenotomy, before applying the Petri casts. During this quick procedure, the surgeon makes a tiny incision in the groin and severs a tendon in the hip called the adductor. The tendon grows back within a few months, allowing your child to move his or her hip more normally. After the cast is removed, usually after 4 to 6 weeks, physical therapy exercises are resumed to restore motion in the hips and knees. Your doctor may recommend continued intermittent casting until the hip enters the final stage of the healing process. Surgery is most often recommended when the child is older than age 8 at the time of diagnosis, because the potential for deformity during the reossification stage is greater in older children. When more than 50% of the femoral head is damaged, keeping the femoral head within the rounded acetabulum may help the bone grow into a functional shape. And if non-surgical treatment has not kept the hip in correct position for healing, I will explain the different options of surgical treatments respectively. Core decompression and injection of bone stem cells into the femoral head. Core decompression surgery is only recommended in the early stages of Perthes disease, before the femoral head has collapsed or flattened and no longer fits neatly into the hip socket. During core decompression, a wire with a 1 to 2 mm diameter is used to make small holes in the femoral head, to stimulate the healing process of the core of bone that is inside the femoral head and to expedite the healing process. These holes relieve pressure and allows for the growth of new blood vessels. The wire is inserted through a small incision and is then guided through the femoral neck into the center for the femoral head. The main concern of this type of procedure is the potential harm that could be caused by the wires crossing the growth plate in the upper thigh bone. There is no evidence of harm to the growth plate, and the rate of successful around 70% for this procedure. The bone stem cells are harvested through a simple needle aspiration from the part of the hip bone that is at the waistline, iliac crest. A special needle is then inserted into the core of the femoral head and the bone stem cells are injected. After the procedure, a Scottish Rite brace is worn during the day and at night. Eventually, when the range of motion of the hip is maintained and stabilized, the brace is worn only at night. After the core decompression and stem cell injection, the child returns to the clinic for follow-up visits every 4 to 6 weeks during the 6 months after surgery. Children who have this surgery may use crutches during this time to avoid putting pressure on the joint. It should be emphasized that the basic stretching exercises are still very important and still need to be performed 2 to 3 times per day. Hip distraction. The doctor may recommend hip distraction for children with more severe symptoms that cannot be treated using other methods. During this procedure, the surgeon attaches a device, called an external fixator, to the hip and upper leg. The external fixator holds the femoral head in the cup and maintains perfect containment. The fixator also gradually reduces compression in the hip joint, allowing it to heal without harming tendons and ligaments. Tenotomy is performed to allow the hip joint to become more mobile so that the femoral head can be placed into the proper position inside the cup before the external fixator is applied. In children with severe symptoms, hip distraction may be combined with core decompression and injection of bone stem cells into the femoral head. The device may be kept in place for 3 to 6 months. Because it provides stability, children are still able to walk while wearing an external fixator. The child will learn to walk with either a walker or crutches with 50% weight bearing allowed on the affected hip during the 4 months that the external fixator is worn. The doctor may recommend the physical therapy, which can help your child to regain range of motion in the hip during recovery. After the external fixator is removed, a Scottish Rite brace or a special abduction pillow with Velcro straps is worn by the patient. The child will be able to walk and to sit while wearing the brace or pillow. This brace or pillow is worn full-time 24 hours a day for 4 weeks. The child will start wearing the brace or pillow only at night and will continue to do this for the next 3 to 6 months. After the external fixator is removed, the physical therapy and home exercise program is essential. The child will need to return to the clinic for a follow-up appointment 6 weeks after the external fixator is removed. After that appointment, additional follow-up appointments will occur every 2 to 3 months for the first year so that we can monitor the hip. When more than a year has passed, the number of office appointments per year decreases to only 1 appointment every 6 to 12 months until the child is approximately 18 years old. The goal is that 6 to 8 months after the external fixator is applied, the child will be able to participate in all physical activities. The Perthes exercises need to be performed daily, but they need to be done only once a day. The Perthes exercises continue until the child graduates from high school. Femoral and/or pelvic osteotomy. Osteotomy is a procedure in which the surgeon resets misshapen bone and secures it within the hip socket by deepening the socket or changing the position of the femoral head. The surgeon can perform a procedure known as a femoral osteotomy, which reorients the way the femoral head fits inside the hip socket. The bone is then secured with a metal plate and screws. The goal of surgery is containment. The idea is to keep the femoral head within the acetabulum. The socket part of the joint can serve as a mold to help the fragmented femoral head retain its round shape. Sometimes, the socket must also be made deeper because the head of the femur has actually enlarged during the healing process and no longer fits snugly within it. In order to protect the repair and maximize healing, there is a possibility that your child may need to be placed into a cast for 6 to 8 weeks after surgery. After the cast is removed, physical therapy will be needed to restore muscle strength and range of motion. Crutches or a walker will be necessary to reduce weight bearing on the affected hip. Your doctor will continue to monitor the hip with X-rays through the final stages of healing. Successful treatment means that the child is free of pain and can return to all previous activities even if the shape of the femoral head is not ideal. The 2 most important factors that determine your child's outcome are their age at the onset of treatment and how much of their femoral head is affected. Children who are younger than 6 to 8 years have a better prognosis. Perhaps because more time is permitted for femoral remodeling and because before 8 years of age the acetabulum is plastic and can mold to the deformed femoral head, maintaining congruity. More than half of the children with Perthes disease return to normal activities within a few years from the beginning of the disease. The development of Perthes disease when the child is older than 8, the development of poor range of motion, and the presence of a non-round femoral head even after treatment usually carries a worse prognosis. It is estimated that approximately 50% of those patients will need a hip replacement by later adulthood, between 50 to 60 years old.